Hi, my name is Justin Gaddy, and I'm going to present an assessment tool called the Brief 2A today, and I will get into specifics, of course. What this is I kind of look at it as a um, big, excuse me, how the hell do I get that up? Dock to top. There you go. Okay, no, I want to keep, okay, more share, fine. Hello. Hello, my name is Justin Gaddy, and I'm going to present a hello. My name is Justin Gaddy, and I'm going to present a an assessment in behavioral care in primary care settings, which is called the Brief Two, and I'll get into the details. Um, Using this, you can go through, but essentially what it is it's creating a triangle. So it's also called the collaborative care model. There are a couple other ones that are synonymous with this kind of not necessarily assessment, but more of a linkage. So it links now um, your primary care. So if you were to go to the doctors, you'd fill out said form or brief A to assess if, and I'll get into that as well. Um, then if your primary care, gets a certain result, then they would. The theory is have a behavioral health um, or mental health consultant there. One we were able to do that as well once we get qualified, and then after that, they're offered um, well anywhere from 4 to 6 30-minute sessions with the clinician if they really do want mental health. And then it bridges to the an NP or a psychiatrist, basically a prescriber. So there's kind of still this cohesive, good communication. Um, so now I'm going to go back to my notes here. The title you can see, and I'll get into adult version, and they're different versions. Other authors you can see that they obviously have a lot of good things going for them. Publisher is Psychological Assessment Resources, or PAR. The data publication, so it was November 15th, 2024, and the child adolescent version, Brief 2, was published early in 2015, while the original adult Brief A was published in 2005. So you can see kind of how it's evolving. In order to practice this as a behavioral health consultant or mental health consultant, you have to have a qualification level of B, which is for them required. Level B is requires a master's degree, doctorate, or license in psychology, education, medicine, or closely related field, and has certification in this professional organization that requires appropriate training and experience in the psychological assessment. So there's a good amount of evidence and evidence base for the Brief 2A. Let's start with kind of a what it can do. So it's a standardized measure of everyday executive functioning in adults. You can see how that can be very helpful. Assesses the executive function behaviors in real world scenarios or settings. Same thing. Builds on the established research base of the brief A and should be used as a part of really of our comprehensive clinical assessment and shouldn't be used alone as a, path to diagnosis or just treatment. And what it assesses in a nutshell, and I will go into this a little bit more, is there are three things: self-regulation, cognitive control, and everyday executive functioning skills overall. So the purpose of this brief 2A is a standardized psychological assessment that is used to evaluate executive functioning in adults. So it starts by evaluating adults and their executive functioning. It also helps clinicians identify difficulties with self-regulation and cognitive control that affect everyday functioning as well. And it's commonly used to assess individuals with attention deficit / hyperactivity disorder, ADHD, autism spectrum disorder, or ASD, traumatic brain injury, sometimes TBI, and other neurological or mental health conditions that may impact executive function. So the assessment results really help inform a diagnosis. They guide a treatment, a plan, and support the development of these individualized interventions. So it's not this standalone tool. And the brief 2A typically takes about 10 to 15 minutes to complete, make it practical and efficient for evaluating executive functioning in adults. I'll go into a little more detail with that. So what population should we use this on? Well, it's designed for adults, this version. 18 to 55 is one, and then I've also seen one that said 18 to 99 years old. But this was the preferred age. Yeah. So it's to assess executive functioning skills and difficulties. So the clinical applications that are useful in evaluating different conditions. So these are executive function conditions: the ADHD, traumatic brain injury, mild cognitive impairment, autism spectrum, mood disorders, anxiety disorders, and other neurological or psychiatric conditions that affect our executive functioning. So you can see how broad it is. The role in clinical evaluation is often included as part of a comprehensive psychological assessment, really to kind of identify challenges or strengths, part of everyday functioning for the patient. And uses in practice, they support the diagnostic decision making, this assessment. They develop individualized treatment plans. They help guide rehabilitation strategies, and they help monitor progress and effectiveness of interventions over time. What are the technical features of this? Well, technical contains 70 items assessing the executive functioning skills. Uses a 3-factor model, which is kind of cutting edge, which number one is the behavior regulation index to note impulse control and self-monitoring. You'll see why this is important. Emotion regulation index for emotional control, adaptation, excuse me. Then there's also the cognitive regulation index, or CRI, and that targets the memory, planning, organization. There are types of items on these. So there are different assessment forms. They include self-report and then the informant report. An informant, they consider, a close friend or relative. So mom, sister, best friend, can be a nurse, could be just another person, to back up basically what's going on, and get multiple perspectives on how they're doing. Then there are validity scales. There is inconsistency a bit. There are checks for contradictory responses. There's negativity, which identifies overly critical reporting. And then there's infrequency, which detects usual response patterns. There's reliability that demonstrates strong reliability with internal consistency scores typically ranging from 0.80 to 0.95, and shows stable results over time. You can see they're pretty strong. There are norms standardized on more than 3,200 adults, 18 to 99, match groups, match samples that includes clinical comparison groups, Parkinson's, dementia, schizophrenia, spectrum disorders. What are the practical features of, because we just talked about technical features, practical features of this brief 2A. So some practical features, the adult age range, you can see there, I put 18 to 99 again. The administration, it takes 10 to 15 minutes really to complete. And it's flexible in its format. It's available in paper and pencil, and then also digital formats. This is the difference between the self-report form and informant form. It allows assessment from the adult's perspective, which is an informant, and from someone who knows the individual well. So like I explained earlier, it also provides executive everyday functioning. So focusing on executive function difficulties in the real world. There are multiple scores that come out as well. And these provide, assessments on behavioral, emotional, and cognitive regulation, along with an overall kind of picture of this executive function. There are easy clinical interpretation. Standard score help clinicians identify areas of relative strength and difficulty. So that makes sense as well. Continued on the next column, it can be multi-rater comparison. So self and informant ratings can be compared to identify the differences in perceived functioning. The progress monitoring can be used over time and see how that's progressed for a person. There's a broad clinical applicability that can support assessment and treatment planning for concerns such as ADHD, TBI, neurological conditions, other conditions that are also affect this. There are older adult applications. So the older adults, I guess to 99, makes it useful across young, middle age, and older adults. So it doesn't opinionate one side or the other. There is also a Spanish language option and supports use with Spanish-speaking adults in appropriate clinical settings. And I will talk more about that in the social, later. So there are updated norms as well. It uses a contemporary U.S. normative sample designed to improve population representation. So those are some practical features of this assessment. This is, I went through this, but I thought it would be a good slide to just compare. And so you have the practical and technical, right? So we just went through them. You can see them yourself. You can go through them, or you can also, I can give you these at the end. So social justice and multicultural considerations. From a multicultural perspective, clinicians should really interpret the brief 2A results within the individual's cultural, linguistic, and environmental context. The executive functioning behaviors such as organization, independence, emotional expression, emotional expression and self-regulation are influenced by cultural norms, family expectations, socioeconomic conditions, chronic stress, and experiences of discrimination or trauma. And without consideration of these factors, we do risk the fact of over pathologizing certain behaviors that can represent adaptive responses to environmental demands. So a culturally responsive, trauma-informed biopsychosocial model is therefore essential when interpreting the brief 2A results. And we've all had practice with that. So there's some also multicultural considerations that go and a little bit more. One thing that I love is that there's a Spanish language form. And I'm also, I lived in Spain for a while, so I'm fluent in Spanish. So who knows? That'd be kind of neat. But there also kind of points out the cultural differences within different communities, how they look on things and how they process things in certain situations. I think that's very important. The informant ratings should be interpreted again. So we're kind of repeating the same thing within the context of the informant's cultural values, expectations, and belief about behavior and self-regulation. And it says there, recommends clinicians should consider such factors. The scores should not be interpreted in isolation. They should be integrated with interviews, observations, collateral information, and other assessment data. Individuals from diverse cultural backgrounds may differ in their willingness to endorse symptoms or difficulties, potentially affecting the self-report responses. Brief 2A should be used as part of this culturally responsive process that considers an individual's cultural and environmental context. And clinicians should avoid assuming that elevated scores reflect psychopathology without considering cultural, linguistic, or situational factors. Some strengths of the assessment are it has the diverse normative sample available of Spanish forms in that. There are multiple informants that can provide culturally context perspective. And we also talked about a few strengths earlier on as well. And, there are some limitations, like everything. The norms are primarily based in US populations and may not generalize to all, cultural groups internationally. There are cultural differences in self-disclosure, emotion expression, behavior expectations that can influence these. And translation alone does not eliminate potential cultural bias in item interpretation. So let's look at the social justice considerations for this assessment. We have to ensure equitable access to the assessment by considering the language, literacy level, disability accommodation, and other financial barriers. We use the Spanish language version or qualified interpreters when appropriate to reduce linguistic bias. Recognize that systemic inequities, poverty, discrimination, limited education opportunities, trauma, and chronic stress can affect executive functioning and influence assessment results. Then we talked about trying to avoid over pathologizing behaviors that can reflect environmental or other stressors rather than executive function deficits. So interpreting these scores based on those contexts, we talked about that. We use multiple sources of information. So all the other tools we talked about, clinical interviews, everything to support, and not to use this as just a direction tool, not a standalone. And where we can come in is advocating for appropriate accommodations, supports, services when assessment findings identify functional impairment. So we also need to be aware of the implicit bias and avoid making assumptions on any of these factors, race, ethnicity, gender, identity, age, disability, or socioeconomic status. Explain the assessment results in clear, accessible language so clients can understand and participate in treatment planning. And yes, if you do have someone that is speaking and it's smart to get a third, an interpreter who's neutral. So I don't, even with my client. So we talked about that a little bit. So we use these assessment findings to promote actually the patient's strengths, self-determination, and equality, equitable access to care rather than to reinforce stigma or discrimination. And these are my references. So thank you for listening.